Hello, and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and anything else. This is the week of July 10th, 2023. And again, has some very interesting questions as we continue to move away a little bit from COVID focus and toward all sorts of other interesting things, including developments in new infectious disease awareness and funding issues. First question actually has to do with a unwelcome guest, that being malaria in the United States. And the question asked, with the recent resurgence of malaria in the United States, are there any specific considerations or guidelines that we as healthcare professionals should follow when encountering a suspected malaria case? So yeah, great question, very timely, thank you very much. In terms of where this comes from, I think many of us have seen reports out of Texas and now increasingly Florida of cases of what are felt to be orthodontitis. I try to say that 3 times fast. Basically, cases of malaria which were not imported by travel, but instead arose from infected mosquitoes here in the United States, and specifically in those 2 states, Texas and Florida. It is not a big surprise that should happen when one considers several things. First of all, the specific species of Plasmodium, which is causing the malaria cases in most states, is Plasmodium vivax, which is the predominant strain of malaria or malaria-causing Plasmodium in Central and South America. So if one then considers that a majority of our international immigration comes from countries in those 2 parts of the Americas, it makes sense then, therefore, that most imported cases of malaria are probably due to Plasmodium vivax as well. If then a mosquito takes a blood meal from an actively infected visitor or international immigrant and then replicates, then indeed we could have like small local pools of mosquitoes which are affected and infected by that specific Plasmodium, and therefore we could have local spread and our own native cases, that being easier to say than orthodontitis. So that's where this comes from, and so far the reports are coming just from those 2 states. It makes sense, however, and appropriately as the questioner is asking, it makes sense to consider that additional cases could certainly arise elsewhere in the country, and certainly here in Arizona, where we have a fairly robust immigration of peoples coming from Central and South America. So what does one look for? And this kind of makes sense to answer even for people with a known travel history to areas of the world which are affected by active malaria. So as we probably remember from medical school, the classic patterns of quaternary or tertian fever occurring every 3 or 4 days, or in the case of Plasmodium falciparum, occurring every 48 hours, where patient in between is okay, not great, they have some malaise, but then they have acute onset, high spiking fevers with rigors, night sweats, shaking chills with muscle myalgias, etc. All of these things would be a classic presentation of malaria. However, that's only after the organism enters into its intraerythrocytic life cycle, in this case the human body. The initial days or weeks of acute malaria are very much like really severe flu, including, bad myalgias, nausea, some vomiting, again, fairly robust fever spikes with rigors, and many times headaches as well, including retroorbital headaches. For those who have experienced this or perhaps have diagnosed this, that sounds a lot like the early stages of dengue as well, which is another mosquito-associated virus. So you sort of see a recurring pattern here. Basically, what to look for is going to be that patient with high spiking fevers, severe flu-like illness, along with the myalgias, the headaches, the malaise, the nausea, that has no other reasonable explanation. And then it is reasonable to consider a diagnosis of malaria. Obviously, the travel history is going to be the most important component of that suspicion, of that index of suspicion. And at this point, since we are not yet hearing about native malaria cases in Arizona, I think it's reasonable to not go overboard on sending testing for the various falciparums, ovales, vivaxes, etc., which are out there. So the approach then, I think, is indeed think about malaria as one of the possibilities, just like you should be thinking about dengue and Zika and chikungunya and West Nile virus, certainly as we are now encountering sort of monsoon season in Arizona, think about it as do I need to exclude this? If I can come up with alternate reasonable explanations, and if the patient has no travel history or no known specific significant mosquito exposure, then it's reasonable to go no further. If, however, there is a major mosquito exposure, if the patient has international travel, and certainly if the patient is living and being evaluated somewhere along the border counties and communities that border with Mexico, then I think it is reasonable to either consult your friendly infectious disease practitioner and or your county health department official, who can then coordinate with you sending testing to the state laboratory, which is the place to send testing for the various types of malaria. In case of those areas which don't have a formal lab arrangement with the Arizona State Laboratory, it is also reasonable to at least ask for a peripheral smear. In fact, several of our imported cases of malaria, all these are Vivax still, have been picked up by very astute hematopathologists or laboratory technicians when looking at the smear of a complete blood count and realizing, oh, hey, I think I see some ring forms or schistozoites in those erythrocytes, and then notifying the clinician. So it is reasonable to ask your local laboratory to consider looking for malaria, and if they're able to do a thick or a thin smear, if that is what the current level of service is in the laboratory, great, wonderful, request that. Otherwise, then I think your next option is to go to the county health department officials and help, or let them help guide you in how best to test those patients. I will say we've had now in my local hospital several cases of malaria, all of which came actually from Ecuador in young people who were traveling unaccompanied up from South America, up through Mexico, and then wound up into one of our border patrol sites that were picked up that way. So just have that index of suspicion, and if you think about it, ask for a peripheral smear on the CBC and or call your county health department. All right, next question, again very timely. It was recently released that the CDC is reducing funding to states for child vaccination programs. Do I see this impacting research and development for new vaccines, or is this mostly to halt ongoing programs and projects? So again, the backstory here, unfortunately, as part of the debt ceiling negotiation between the Biden administration and Congress, a fairly significant chunk of change was removed from CDC's budget and also affecting unspent dollars for COVID response. The upshot of this is, in specific regard to this question, that immunization managers in all the states, and 27 states specifically, received notice that they would be having this budget impact. They were notified that they would be having approximately a 10% cut in the normal grant funding which that state receives to support vaccination programs for children. Now, immunization managers, what does that mean? These are typically the managers through the state health department who are ultimately responsible for directing state programs to increase vaccinations, routine vaccinations against routine childhood illnesses such as chickenpox, measles, mumps, rubella, tetanus, pertussis, etc. So it is not specifically a cut in the funding, the vaccines themselves. The cut in funding is affecting programs that identify communities and people who are vulnerable to disease outbreaks. So think of everybody experiencing the social determinants of health and in under-resourced areas who are, of course, most at risk to become under-vaccinated and to have outbreaks of vaccine-preventable diseases. It is specifically a cut to those programs that identify those communities and develop resources to try and reach out to them. So what is ultimately going to happen is that there will be a decrease in data collected by the individual states of those peoples, and a decrease in the data then reported to the CDC, and therefore a decrease in how nimble our health department officials and the CDC can be in responding to areas of underserved communities and under-resourced peoples. So that is the ultimate upshot. It is not anticipated to affect research and development for new vaccines, and it's not going to halt any active programs. But of course, any decrease in funding is always going to have repercussions in terms of decreased staffing, decreased ability to generate interventions and data which is necessary. Just out of interest, this same debt ceiling negotiation deal that was reached is rescinding $27 billion in unspent COVID funds, which have been sitting there they're being underused. And it also, as part of that, decreases by $480 million funds for state workers who negotiate and navigate sexually transmitted infectious disease response. So that's quite pertinent to Arizona, as we are top in the country, in the top 5 at least, for primary, secondary, congenital syphilis, and we're not doing too awfully well in terms of gonorrhea, chlamydia, trichomonas, and other fun things. So there will be an impact which is not yet known in terms of the extent in the ability to be nimble in our response to sexually transmitted infectious disease responses as well. So none of this is good news. It is obviously without getting too political here, it is an outcome, unfortunately, of the very tense and fraught negotiations at the federal level, and there have been no clear winners, I think, certainly in terms of public health response because of that. So that is the answer to that. So new vaccine research ongoing, and especially including some very exciting new targets using messenger RNA vaccine technology, which will continue and have continued to go forward. And I expect we'll be hearing more about that going forward from both the pharmaceutical companies and also peer-reviewed journals. So stay tuned for more. Next question. With foodborne illnesses returning to pre-pandemic levels, yes, that was another media report, do we think we as providers will see an increase in Campylobacter and Salmonella cases? 100% yes. In fact, we already have. It has been a weekly occurrence to have at least one, if not more than one, acute bacterial enteritises, that being Campylobacter, Salmonella, and Shigella, currently having a mini cluster of babies with neonatal salmonellosis. The variety of exposures. One was actually raw chicken exposure from a well-meaning but misguided grandparent. Another potentially was related to the parents' vocation and their exposure to raw sewage. So certainly it is evident that Campylobacter, Salmonella, and Shigella are being seen in increasing numbers in sewage and wastewater sampling, and certainly in terms of clinical and community cases. Typical presentation is always an initial prodrome of 1 or 2 days of nausea, some emesis, malaise, and then developing diarrhea with varying degrees of severe abdominal cramping and varying degrees of acutely bloody diarrhea. Campylobacter, of the 3 of those, Campy, Salmonella, and Shigella, is the least severe, but that is not to minimize, because anybody who's had Campylobacter enteritis knows that is not a walk in the park. Typically 5 to 7 days of microscopic or grossly bloody diarrhea with mild to moderate cramping, nausea, vomiting, decreased oral intake, and typical admissions are due to dehydration. Salmonella is next in the higher degree of severity in terms of all of the above, and Shigella is at the top of the pile with severe crampy abdominal pain, tenesmus, that rectal pain upon defecation, grossly bloody stools, dysentery-type presentations, which include some patients with hemodynamic instability and shock. So, yeah, it's out there. We've been seeing it. High index of suspicion, low threshold, I should say, to send testing. Do remember that along with those 3, Campylobacter, Salmonella, and Shigella, there are also out there enterohemorrhagic E. coli's producing Shiga-like toxin, and that toxin is a nasty because it has an association with hemolytic uremic syndrome and other bad things. So rather than empirically treating every patient with bad diarrhea with an antibiotic, it is important to try and establish a diagnosis which will then help you identify if the patient does deserve treatment, and if so, which one. So Campylobacter most often resolves spontaneously after 1 or 2 weeks, and it is rare that one would need to treat that with a macrolide, meaning azithromycin. That rare would be the patient who is immunocompromised or immunosuppressed, very young or very old. Again, not typically our patient population for geriatrics, but certainly infants and children with Campylobacter will do better faster if they're treated. Salmonella, we almost always leave alone. We do not touch that with antibiotics unless it is a baby under 3 months of age or a child, again, living with immunodeficiency, immunosuppression, an oncologic diagnosis, etc. Shigella most often is treated, if only to try and reduce the number of days of severe discomfort and the losses of blood and water from the diarrheal illness, but because that illness most especially strongly resembles that related to enterohemorrhagic E. coli and Shiga-like toxin, it is very important to make sure there's no Shiga toxin in that patient's stool before beginning an empiric course of of antibiotic. Clearly that this is the kind of situation that might deserve or benefit from at least a phone consultation with an ID provider, and or sometimes hospitalization for observation and very close decision making based on the patient's status. So yep, folks, it's there, it's out there. It is the so-called picnic months in the rest of the country. It's hotter than Hades here, and which doesn't seem like picnic month to me, but this is when we see our clusters of cases, that being usually May into August and September. So stay tuned. There's plenty out there which can cause all sorts of fun diarrheal illnesses. And then the last question, again, this is near and dear to my heart as a recovering infection prevention officer for a large hospital system. The question asks, a recent article mentions a children's hospital in Virginia which successfully reduced their central line associated bloodstream infections, aka CLABSIs, that's the initials we use, for 332 consecutive days. Do I have any best practices to recommend or that we're following in our hospital to hopefully duplicate those response? So yeah, thank you for that question also. So the specific hospital is the Inova L.J. Murphy Children's Hospital in Falls Church, Virginia, and it looks like their very astute infection prevention officer was benchmarking their CLABSI rates against other pediatric hospitals, and as the euphemism goes, saw an opportunity for improvement. Basically, that's corporate speak for Houston, we have a problem, we got to fix this fast before we start to lose CMS funding through Medicare and Medicaid, because CLABSIs are hospital-acquired infections that are reportable to the federal government, and exceeding a benchmark rate, which is called a standard response rate. If you exceed that, then you start to lose payment on all those billings we send to Access and other things like that. So this particular hospital realized they had a problem, convened a multidisciplinary committee, which had like nurses, pretty much anybody in the front line. So nursing personnel, technicians, environmental services personnel, doctors, neonatologists, OR and emergency department physicians and staff, you name it. And this group got together and first, I think identified sources of the problem, and then focused on several areas of intervention. This I think is where we're going with this question. So they found ways to improve and, I guess improve is the best term. So improve their environmental cleaning process. They also codified how they accessed the lines, and they increased how and when and how frequently they audited those line dressing changes and line access times. They also focused very specifically on how and when and with what technique central lines were removed, also how to maintain proper line care, and they had daily rounding by this multidisciplinary team on patients hospitalized with the central line in place. And then finally, and this is a fantastic collection of interventions, not least of which is this last part, they provided patient education to expect and anticipate better hygiene performed, both oral, personal, and hand hygiene, by nurses, physicians, and other staff, all of which then contributed to this significant drop in the CLABSIs. So 332 days without a CLABSI. To put that even more perspective, although that's 332 calendar days, it's even better when you look at the number of days of patients in hospital who had a central line, and that was over 10,000 days. So that's fantastic. They went 10,000 patient central line days without a CLABSI, which is that's astronomical. And I imagine that first patient who had a CLABSI had everybody weeping and crying and gnashing their teeth, and I imagine there was probably a very focused response to that specific event as well. So in terms then of interventions and best practices, there are a couple things which are very important to note. The first is that hygiene surrounding the central line is perhaps the most critical. So whether it is changing tubing, for example, a patient is on TPN or on some continuous infusion medication, and changing the tubing rather than 48 hours or 72 hours, changing it every 24 hours with a new bag of TPN. Being very, very diligent in how one accesses the lines for blood draws, minimizing blood draws, first of all, and then how one accesses for blood draws, and also how one changes over the tubing. If dressing changes are performed, and not all lines have those frequently, for example, neonatal PICC lines are typically not changed, but other implanted tunneled catheters are. But changing the central line dressing using sterile surgical technique, and also using a two-person process. So it's not just bedside nurse changing the dressing, it is bedside nurse and another bedside nurse together in surgical scrub attire, who are doing that dressing change together. So it's reporting listening, observing each other, looking for flaws or breaks in technique, and then just making it an issue, I think, is perhaps the number one way to decrease lines. Increasing awareness and increasing focus on preventing collapses is the best way to make sure that no collapses occur. And especially if then breaks in hygiene, breaks in integrity of dressing or line or skincare, etc., happen, to then have a formal, appropriate response to those. So major, a round of applause to Murphy Children's Hospital in Falls Church, Virginia. Well done, y'all. That is a great outcome. They, by the way, it looks like just reported that, it looks like in a poster format in the APIC meeting, which occurred at the end of June, just a couple weeks ago. So well done, y'all. That's fantastic. So that is it for the questions for this week. In terms of what else is out there, unfortunately, we still continue to have a sporadic case or two every week of COVID-19 in pediatric patients. Typically, the patients coming in for either combination viral illness, so respiratory distress, oxygen requirement, potentially due to both and or happens to have been COVID-19 SARS coronavirus 2 positive and was admitted for something unrelated. But regardless, there is still SARS coronavirus 2 circulating in our communities here in Arizona and, of course, elsewhere in the country and the world. Along with that, respiratory illnesses are trending down, thankfully, from our very unfortunate peaks not so very long ago, but still seeing a fair amount of adenovirus out there causing all sorts of things from pink eye to flu-like illness to pneumonia and pneumonia with respiratory failure. So adenovirus is still absolutely out there, as is our dear old friend Group A streptococcus or Streptococcus pyogenes, causing a fairly brisk caseload of scarlet fever. We have had several acute rheumatic fevers now, diagnosed by several major criteria, and including cardiac involvement, and also patients with the typical strep throat, and then developing perhaps a reaction to amoxicillin, which is unrelated to the strep per se, but is either erythema multiforme major or a serum sickness-like reaction to amoxicillin, which is being reported very significantly over the last half year or so. So lots of stuff is out there, and as noted with the previous question, plenty of bacterial and even some viral gastroenteritis is absolutely making the rounds. So I imagine, in fact, know for a fact, that our wonderful colleagues in the emergency departments around the state are keeping themselves rather busy still. They could all use a nice, friendly pat on the back and a vote of thanks if you happen to see one. So with that, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona and other infectious diseases, or to learn how to become a member, please visit us at azaap.org. And if you happen to be joining us in Sedona in just a couple weeks for Pediatrics in Red Rocks, feel free to come over and say hello. We'll all be there. So thank all of you again for listening. Thank all of you for your service. Keep fighting the good fight, and we'll talk to you soon. Thanks all.